My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. Sonic Insights, the makers of Velicure, is sponsoring today's webinar, A New Era in NASH Management. And our presentations today will cover what's new in biomarkers for NASH in 2022 with Dr. Nezam Afdhal, and a current view of the NASH and NAFLD therapeutic landscape with Dr. Stephen Harrison. Dr. Afdhal is the chief of the Division of Gastroenterology at Beth Israel Deaconess Medical Center in Boston, Massachusetts. He's also a professor of medicine at Harvard Medical School, and he's published more than 250 original manuscripts, reviews, and editorials in journals, including the New England Journal of Medicine, Gastroenterology, Hepatology, Gut, and Journal of Hepatology, as well as 40 books, chapters, and 2 books. Our second speaker is Dr. Stephen Harrison. Dr. Harrison is currently a visiting professor of hepatology and alimentary pharmacology and therapeutics. He's known internationally for his studies in non-alcoholic fatty liver disease with more than 250 peer-reviewed publications. Dr. Harrison currently serves as the chairman of Summit Clinical Research and of Pinnacle Clinical Research, LLC. The next hour is going to provide an incredible update. And without further ado, Dr. Afdhal will share his insights into the world of non-invasive testing. Dr. Afdhal, take it away.
Thank you very much, Michael. So for this presentation, I'd just like to state my disclosures. I am a consultant for both EchoSense, the makers of FibroScan, and Sonic Insights, the makers of Velicure. So when I think about biomarkers in NAFLD and NASH, I really think about biomarkers in the clinical sense. So the first clinical risk biomarker is the patient themselves. It's their background of metabolic syndrome, obesity, type 2 diabetes, and hyperlipidemia. That is your clinical first biomarker. And it's also the most common patients we see, although some of us also see patients that don't fit these criteria with lean NAFLD or drug-induced fatty liver disease. When we then go to the next step, and the next step is the most complex step, it's really the association of the biomarker with what is going on in the liver. And if you think about it, we have NAFLD, which is really just simple steatosis, no significant apoptosis, a NASH score of usually less than 4, and a fibrosis stage of 0 to 1, perhaps with minimal sinusoidal fibrosis. This is so-called fatty liver disease. NASH has to have with it not just the steatosis, but inflammation and balloon degeneration or apoptosis. And then there's a new category which has really been developed by clinical trials called at-risk NASH. And these are people who not only have the features of NASH, as listed above, but also have some degree of fibrosis with a fibrosis stage of greater than 2. And then, of course, the most important group is those who have cirrhosis, because the diagnosis of cirrhosis is critical because it requires a different clinical paradigm with screening for portal hypertension and screening for hepatocellular carcinoma. So we want biomarkers that are able to differentiate these various components of the clinical paradigm of non-alcoholic fatty liver disease. These biomarkers have multiple major implications, but I'm going to focus on 2 for the purposes of this talk. One is the utilization of biomarkers for diagnosis and screening, and the other one is how biomarkers can give us prediction of patient-related outcomes. And if you think about it, those are the number 1 and 2 questions that patients ask. What do I have? What's going to happen to me? That's what a patient wants to know when they see you. Now, obviously, if we had treatments, biomarkers should be available to help us make treatment decisions. And I don't mean that in the sense of what should I treat, but treatment-specific decisions according to what the biomarkers suggest is the best single and/or combination therapies. And we'll hear a lot about that from Steve. But think about this as you hear his talk, how the biomarkers can help us make our choices of what to use in terms of whether to use metabolic therapeutics or antifibrotic therapeutics or combinations. Biomarkers have got a lot of use recently for clinical trial enrichment and recruitment. For those of you who are not involved in NASH clinical trials, failure rates for entry into NASH clinical trials can be as high as 80%. Now, that's a huge failure rate. And sadly, most of the failure takes place at the liver biopsy component. And so being able to enrich a population to get a high enrollment rate is both cost effective and necessary for successful clinical trials. And then finally, perhaps the gold standard would be to develop biomarkers for regulatory endpoints for drug approval. Obviously, we do not want to live in the world of liver biopsy. We do not want to have to do liver biopsies to enroll patients. We do not want to have liver biopsies to see if the therapeutics were successful. But I'm not going to talk about those, but those are things that we can talk in the Q&A and after we hear the discussion from Steve. Now, in the world of NAFLD and metabolic syndrome, there are multiple people involved. I like this slide because it tells us who is here. So the cardiologist and endocrinologist view of the world is really type 2 diabetes and metabolic syndrome for endocrinologists, cardiovascular disease for cardiologists. And you can see that cardiology has a big role in this. 735 MIs per year and 610,000 deaths. This is us, the hepatologist view of the world. And hepatologists are a very small component of life, even within the GI world. And you can see that we have a very, very limited view. We look at it from the perspective of steatosis and NASH. We look at it from the risk of development of end-stage liver disease, hepatocellular carcinoma. 40,000 deaths per year from liver disease, less than 10% of what we see from cardiovascular disease, let alone the combination. But the reality is that this disease is absolutely interchangeable and managed often by both sets of people. Why this is important is that the best biomarker is a biomarker that's not just going to tell you about liver disease. It's a biomarker that's also going to tell you about cardiovascular risk and cardiovascular disease. And in the middle sit the primary care physicians, who to them the biomarker is usually just the ALT. And it's not even an elevated ALT, it's usually an ALT of greater than 100. So we have all of these reciprocal activities taking place with different viewpoints from depending where you are. We have spent years working on methods to assess liver fibrosis, years and years and years. You're looking at all sorts of different biomarkers, from the most indirect biomarker, like the platelet count, to very direct biomarkers like procollagen peptides, like YKL-40, like biomarkers that indicate fibrogenesis and in some cases fibrosis regression, combination panels of biomarkers, and then obviously liver imaging and liver biopsy. And I'm going to talk predominantly about the ones that I think are important in clinical practice. I'm not going to focus on some of the excellent work that's being done by the NIMBLE and Litmus consortia that are looking at all sorts of really exciting biomarkers, like proteomic technologies using SomaScan, like talking about genetic biomarkers, or talking about some of the new metabolomics that are out there, because these are still really very much in the research environment. And when one thinks about biomarkers, one has to think about cost effectiveness as well. There's no point having a biomarker panel that costs 10 times the cost of a liver biopsy. So the goal in screening is to identify clinically significant NASH. That's what I teach my fellows. I want to know who has NASH, F greater than 2, and features to suggest apoptosis, inflammation, and steatosis. And I want to identify cirrhosis. In fact, I don't want to miss cirrhosis. I would rather over-identify cirrhosis than miss cirrhosis, because if I over-identify it, at least then I might be doing a few more ultrasounds and screening than I would normally do, but I would not be in a situation where I would miss somebody at risk for a bad outcome. And the sensitivity and specificity are goal dependent. So it really depends what you want to do. If you want to be very good at identifying cirrhosis, you want to have a very high sensitivity. If you want to be very good at only finding patients with NASH greater than F2, for example, in clinical trials, you want a very high specificity. This is data that was presented at the liver meetings just a month ago in Washington, D.C. And it's a very, very nice, simple study. It is really a study of patients referred to a center with biopsy-proven NAFLD. And the study looked at a combination of the ELF test and the FIB-4. The biopsies were all read by a single pathologist, and the clinical demographics are exactly what you would expect from this population. You can see that it's relatively enriched. So overall, around about 35% of patients had stage 2 to 4 fibrosis, and about 2/3 of patients had none to mild fibrosis. In real life, this should be about 20/80, so 20% with significant fibrosis. And again, what we're looking at is people with stage 2 or greater. And this is basically the cutoffs and the sensitivity. And this was a typical study where they tried to create multiple different cutoffs to see what you wanted. So if you wanted a cutoff with a very high sensitivity so that you didn't miss anybody with F2, F4, the cutoff range is shown there. If you wanted a higher specificity, then you can see the cutoff goes up. But overall, both ELF and FIB4 are excellent in terms of utilization for the diagnosis of significant fibrosis. Anything in reality with an AUC with a lower confidence interval of 0.7 is an excellent test. So you can see here that for ELF, the lower confidence levels were 0.74, and for FIB4, 0.75. We use ELF sometimes, but basically, this also supports the excellent response of a very simple test like FIB4 for its ability to diagnose fibrosis and its utilization in clinical practice. Again, the caveat with this study is that it's slightly overweighted towards those with more significant fibrosis. I want to turn to imaging because imaging is a very important component of what we do. And it's really, for us here at the BI, the major way in which we look at our patients with NASH. There are multiple imaging modalities. There's the transient elastography, which is a mechanical transient shear wave that, can go into the liver. Its accessibility varies from which part of the country you're in. Certainly, there's a lot of accessibility in the majority of the major cities. There's shear wave elastography, or ARFE. These tend to be done predominantly by radiologists and are not really as well characterized and have not been studied as extensively as transient elastography. Then there is MR-based technologies. MR-based technologies have often been considered to be one of the gold standards. However, the issue with them is quite honestly, you require an MRI scanner and you require a significant expense associated. And then most recently, S-Wave, mechanical steady state wave technology, which uses the similar principles as is associated with MR, with a driver to generate the shear wave and the ability to look at the shear wave throughout the liver. Why are we interested in these tests? Because if you look at our guidelines now, and you look at the ASLD guidelines, you look at the AGA guidelines, you look at the EASL guidelines, in those guidelines, for people with high clinical risk factors for NASH, there is always an assessment of fibrosis. And that assessment of fibrosis, in every single case, has part of it elastography. And you can see that they're very broad, whether it's MR-based elastography, transient elastography, or shear wave, they don't mind. And they throw in there, consider also fibrosis biomarker panel. It's not 1+1. So you don't need to do elastography plus a fibrosis marker. It's one or the other, and it's one of these different technologies. And then depending on what the results are, whether it's high risk, intermediate risk, or low risk, there are clinical pathways that are indicated for those patients. The American Diabetes Association is way more advanced than we are. They have much more strong recommendations in terms of everybody with diabetes being evaluated, and the most recent guidelines, which came out in 2022, absolutely state that non-invasive tests such as elastography and fibrosis biomarkers should be utilized in every patient with type 2 diabetes. So there is a precedent for this. Now, how well this precedent and these guidelines are followed remains relatively unclear. Certainly, I think, again, it depends upon which part of the country you're in, but we certainly do a lot of screening within our own system of all of our diabetics and also all of our patients with obesity. The standard office-based test for elastography is really there are two main ones that are in use today. One is the Velicure test, which is an external shear wave. You can see in the little cartoon a generator placed under the patient, which generates a shear wave up into the liver. And you can see transient elastography from FibroScan, which has a wave generated by the probe. They have different pathways in terms of how far they travel through the liver. One is a steady state constant shear wave. The other is pulse, so it's pulsed into the liver. One is a single frequency, one is a multi-frequency. The other big difference between them is that you get an image, a 2D image with the Velicure, where you get no image with the FibroScan. Both of them have been well validated, and both of them are highly effective. If you're lucky, you have both of these devices. If you're lucky, you have one of these devices. And if you're unlucky, you don't have any of these devices, because they certainly change the way in which one does clinical practice. I want to give you a little bit of data from the study that we presented at ASLD on Velacure. This is a clinical study with multiple sites, and it essentially looks at liver fibrosis and steatosis, looking at all three elastography measurements commonly used: Velacure, FibroScan, and MRE, MRI, PDFF, taking MRE, MRI, PDFF as the gold standard. And, you know, it's as good a gold standard as liver biopsy is, with the error associated with liver biopsy. It's not perfect, but neither is liver biopsy. And again, this is a multi-center study. AUCs were calculated, elasticity was determined, and attenuation was correlated with the MRI PDFF to measure steatosis. These are the elasticity results. You can see on the bottom is the stage as determined by MRE fibrosis. And there you see the elasticity by the two technologies. And you can see that it's very, very similar. They really do have a good ability. The hardest part you can see on this slide is the ability to differentiate between stage 1 and stage 2. That's where the bars overlap the most. Maybe there's a little bit less overlap with Velacure, but they both have overlap. And here you can see the thresholds and the cutoffs for the various stages of liver disease for both FibroScan and for Velacure. The FibroScan data is essentially taken from the cutoffs as recommended by the company. The Velacure cutoffs and the optimal thresholds are actually currently being developed and validated, but it's good to see that there are cutoffs that are available. You can see that overall, the scale for Velacure is much tighter than the scale for the cutoffs for FibroScan. However, when you look at sensitivity, specificity, and you analyze the two, they are both equal for elasticity. This is the data shown for attenuation for FibroScan. This is the CAP score for Velacure. This is their ACE level. You can see here again that there is a good separation between the different levels. Now, again, one of the things you might ask yourself is, do I really need to know how much steatosis is in the liver? And the answer to that is, in clinical trials, yes. In clinical practice, maybe not. But what you really do need to know is you need to know whether there is significant fat in the liver as part of the diagnosis of fatty liver disease. So I like the 5 to 15%. I like to have a good cutoff and sensitivity specificity for that. And obviously, in some patients, I also like to know the high level of fat, the greater than 20% level of fat. Not sure that I can tell them that it's clinically meaningfully significant, but I am sure that I can tell them that when I use the words, you have a lot of fat in your liver, that it gets them a bit worried. Again, using the same format, using cutoffs for the ACE and the CAP, you can see that they have very, very similar areas under the curve, very good 95% confidence intervals. Remember that rule of thumb. You want to be better than 0.7 at the lower end, and you can see that all of these tests are better than 0.7. Good sensitivity and specificity, and a little bit of a better differentiation in terms of Velacure for high levels of fat. And in fact, that reached statistical significance in this particular trial. So these tests are excellent, and they tell us fibrosis stage, they tell us the fat in the liver. The data confirms the earlier studies, and there are many studies ongoing with Velacure that are reading out over the next 6 months, including studies in cirrhosis. Perhaps the ACE measurement for fat is a little bit better at the higher levels than FibroScan, but I'm not sure what the clinical significance of that is. And certainly they are equally effective at fibrosis stage. Therefore, they are equally effective at determining those with clinically significant fibrosis. And why is this important? This is our paradigm. This is our paradigm for clinical care. Essentially, what we do is a patient's referred to us, we scan them, we see if they have elevated elastography. If they do, then they will go to hepatology. If they don't, they get taken care of in primary care. We have implemented this across all of the primary care sites at BIDMC in our diabetes clinic at the Joslin, and we are scanning all patients with obesity and with diabetes. Our goal at the end is to even think about scanning all patients over the age of 40, to really utilize this as a screening test for all liver diseases. And then this paradigm is what we follow. And so it's very simple. It avoids a lot of unnecessary referrals to our liver group. I'm going to turn very quickly to prognosis. Prognosis is incredibly important. What does a patient want to know? The patient really wants to know what's going to happen to me. And prognosis is the actual true approvable surrogate marker. So if you have a marker that tells you the prognosis, so it tells you what will happen in 5 years, whether there's a clinical outcome going to happen or not, that is a truly approvable surrogate marker. So that is really the goal of not just what we're doing here, but also how we try to develop biomarkers from the NIMBLE and Litmus consortia to determine a true surrogate. We know that mortality goes up in diabetes. It goes up even in people with just isolated steatosis. As you get more liver disease, more liver-related mortality goes up, but even isolated steatosis is associated with an increased risk of cardiovascular mortality. So fat in the liver is a bad thing, and we know this. So the ability to try to get a prognosis based on our tests is very, very important. So there are two studies that I predominantly want to talk about. They both come from the UK because the UK has excellent observational cohorts. This is the first study. And this study replicates many of the things that we've done here in the US, including in my group who've done a very large study, using something really simple like FIB4. This is taking patients who have visit the general practitioner, so it's like a primary care system. They are included in the study with the following inclusion criteria. They have a FIB4 determined at baseline, and the FIB4 category is low risk, less than 1.3 indeterminate, and then high risk greater than 2.67. And it's time to first liver event, and that's hospitalization or death. So they're real liver events. Time to first cardiovascular event, time to any cause of death. This is the patient population. It is large. It is around 45,000 patients were followed in this observational study, and they were followed for a significant period of time, almost 10 years. And you can see those people with high FIB4 levels had a 15% cumulative incidence of liver events, 61% cumulative incidence of all-cause death, and a 33% incidence of cardiovascular events. And indeterminate was between low. So what you really want is even interestingly, an indeterminate FIB4 had more cardiovascular events associated with than liver-related events. So this tells you that the FIB4 is an important test. If I have a patient who has a high FIB4, what would I do? I would certainly say to them, well, you need to have liver-related evaluation, but we would also probably refer them all to a cardiologist. And this confirms previous data and data generated within the US. And when you look at the adjusted hazard ratios for this, you really see that they get pretty damn high. Look at FIB4 high hazard ratio, 16.46, with very large confidence intervals. And it's almost as good as the Framingham Heart study. So this is comparing just the simple FIB4 to what your cardiovascular risk is or mortality risk with the Framingham Heart study. So very, very close. And it's very good at predicting cardiovascular events, just the same as the Framingham Heart study. So an incredibly simple test with a huge amount of prognostic information. This is the more important study. This is the follow-on. So this is the study that after they got the baseline FIB4, what they did was they followed these patients and they looked at 12-month changes. And then they looked at outcomes again using the same criteria. And they looked at the change in FIB4 and they looked to see if the change in FIB4 had any prediction of what happened. So here you go. Same categories. Baseline FIB4 high, indeterminate, low. 12-month FIB4 change goes up in the solid lines, goes down in the dotted lines. Just look at the red group. So the red group are the people with the high baseline FIB4. If your FIB4 went up, you went from a risk of an event of 12% per year to 18.5% per year. Rising FIB4s, not a good thing, all right? Then look at what happens if your FIB4 went down. Again, you had a reduction in your risk of events by about 3%. This is incredibly interesting because what they also did here was that they calculated how much of a change in FIB4 was associated with how much of a potential benefit in risk or reduction of risk in having a cardiovascular event. This type of data will change how we approach patients. The same stuff has been done for liver stiffness. So this is data that comes from the NASH CRN. And what they did was they looked at their patients over a period of time, almost 1,000 patients. Again, these are selected because the previous two studies are unselected. These are selected. And what you see here is that increases in liver stiffness over time are associated with an increased risk of poor clinical outcomes as determined by liver-related events over time. And you can see that as your liver stiffness went up over time, your risk of liver-related events went up over time. And again, progressors whose liver stiffness went up and went into the cirrhotic range had an increase in terms of liver-related outcome versus those who did not think. So again, changes in elastography are also predicted. So one can see that, for our patients, people often ask me, how often do you do these tests? I do them now. I used to do them every 2 to 3 years. But now, honestly, I do most of these tests annually in my patients. They get a liver stiffness evaluation either by Velocure or FibroScan, and they get a FIB4, which is part of standard clinical practice. And, we look at the changes and we see if the changes persist over 2 to 3 years, we think that person is at risk for progressive liver disease. NASH is big. It's getting bigger. The morbidity and mortality from all causes is increasing, and us as liver disease, we're the small potatoes. We're 10% of the outcomes compared to cardiology with 90%. And in my opinion, elastography is leading the way, both in terms of screening and also with the potential in combination with biomarkers like FIB4 for determining prognosis. I'm going to turn it over to Dr. Harrison to move into the area of therapeutics and tell us what's exciting in the NASH therapeutic landscape. And there's nobody better to do this than Stephen, who has led a huge number of the clinical trials in NASH, not just in the US, but globally. Stephen.
Okay. Well, listen, even small potatoes can give you fat in your liver. So we, got to be cognizant of that. But again, thanks for the wonderful introduction. Let me jump right into the therapeutic landscape and where we are today. Let me preface this by saying it's an exciting time to be studying drug development, focusing on drug development in fatty liver. I feel like we're on the precipice of really some magical drugs to help treat this liver disease. Feeling a little bit like the Hep C world in the days right before we had direct acting antivirals available. So these are my disclosures. And just talking about the NAFLD-NASH therapeutic landscape, just to put this in perspective of where we are, phase 1, over 50 trials currently, over 30 trials in phase 2. The trial phase where we begin to do liver biopsies is phase 2B, where we do paired liver biopsy trials, looking to find an efficacious dose of drug against our regulatory endpoints. We have 15 of those underway, and we currently have 4 phase 3 trials underway right now. So this is a monumental effort, Herculean effort, to try to find drugs to treat this bad liver disease. Now, it goes without saying that in anything there is drug failures, and there is no exception with fatty liver. The graveyard is full of failed drugs for NASH, and there are numerous ones listed here. And I will say that I've been a part of all of these except one. And I don't shy away from that, because just like Michael Jordan said, he learns more from failure than success. There have been very specific nuggets, pearls of wisdom that we have taken from every one of these trials and have applied those toward the new trials that we're doing today. So while these specific therapeutics have not made it forward in drug development, we've taken many of the lessons learned and applied them to new drugs. Where are we at with the regulatory framework? Well, the goalposts have not moved. We still have to hit histopathologic endpoints to achieve conditional approval. Now, conditional approval means that you have hit a surrogate marker for predicting outcomes, and you can begin to market and sell your drug, but you have to go on and do additional studies to show that those surrogates actually are linked to long-term clinical outcomes. And so generally speaking, we do a phase 3 trial to get Subpart H approval, and then we either continue that phase 3 trial for outcomes over the longer period of time, or more recently, there's been a pivot to where we enroll a well-compensated cirrhotic population of patients and look for outcomes there. So these are the two registrational endpoints. They're both histologic: NASH resolution without worsening of fibrosis, or fibrosis improvement without worsening of NASH, or a combined endpoint of both of these. Now, this varies slightly from the EMA, where you have to have both. It's not given either or, you have to have one, you have to have both, not just either or. So when we look at the ongoing phase 3 trials, I often get asked, tell me about the maturity of the program, when we can anticipate hearing something. So with the RAM call, they're on hold currently. With resmetirom, the first phase 3, looking at safety and tolerability, read out earlier this year. I presented that at EASL in London this past summer. But the surrogate endpoint study, the registrational trial study, Maestro NASH 1, is anticipated to read out before the end of this year. So buckle your seatbelts, because it's already towards the end of the year. We have about 2 weeks left, and we're hoping to hear something any day. Obeticholic acid has already read out its initial phase 3 registrational trial. There was statistical significance. We'll go over that momentarily for fibrosis improvement. A new drug application was submitted and it was rejected. Now, they have recently reread, using a different methodology, the same 931 slides, and have shown very similar statistical significance on fibrosis, but they have a larger pool of safety data. And the word is they are submitting to the FDA before the end of the year for a new drug application. Semaglutide and lanifibranor are really in the middle of enrolling their phase 3 trial. And looking at guidance from clinicaltrials.gov, we see that Q2 2024 and Q1 2024 for the registrational endpoint trial readouts for semaglutide and lanifibranor, respectively. And then finally, long-term outcome data to be towards the end of 2028. Now, let's focus on the roadmap to patient access. And we're going to talk about obeticholic acid, semaglutide, lanifibranor, and resmetirom. And so let me, and then finally, getting access to the patients. So jumping in, first of all, obeticholic acid is an FXR agonist. So FXR is a nuclear hormone receptor that is central in the role of regulating bile acids, as well as glucose and lipid metabolism. And we see specifically that OCA, or obeticholic acid, targets inhibition of CYP7A1, which, if you look at the little cartoon on the left here in blue, it is the rate limiting step for conversion of bile acids to cholesterol. So when you block that, you downregulate the bile acid pool, and that is anticipated to have pleiotropic effects on collagen synthesis, downregulation of stellate cell activation, downregulation of de novo lipogenesis, and ultimately resolution of steatohepatitis. And you see many of those mechanisms listed here. So the REGENERATE trial is a quintessential phase 3 trial in NASH, 2 doses versus placebo, randomized equally to each cohort, biopsy proven NASH with F2-3 disease, or as Dr. Afdhal mentioned, this at-risk NASH patient, which is NASH with an NAS of 4 or more with F2 or 3 fibrosis. Treatment here was designed to be event-driven, ultimately for its outcome, but a liver biopsy was done for its surrogate endpoint assessment. On the left, you see the interim results, the subpart H approvable endpoint from the original set of data read in 931 patients. And you see a treatment effect delta here of roughly 11% between high dose and placebo, 23 versus 12%, that was statistically significant for fibrosis improvement. On the right, you see no difference for NASH resolution relative to placebo. From a safety perspective, there were some concerns with itching, pruritus, 50% in the high dose group, and potential worsening of lipid profiles with increases in LDL, decreases in HDL, and ultimately increases in gallstone formation and cholecystitis. And that led to the drug ultimately getting a complete response letter and not being approved by the FDA. Now, more recently, there have been a relook at this data, and that data was presented at AASLD recently. Same 931 patients, now a different read methodology showing very similar results. The treatment effect delta actually increased by a percentage point to around 12% for fibrosis. But more importantly, there was over 4,000 patients worth of data collectively looked at for safety, and it does appear that there are no new safety concerns popping up. So that is good news for obeticholic acid, and as mentioned, they are refiling for an indication in the treatment of fibrosis relative to NASH. Now, moving on to semaglutide. This is a GLP-1 receptor agonist. On the left cartoon, you see how that affects this underlying pathophysiological principles of fatty liver disease. But ultimately, the goal here of a GLP-1 receptor agonist is to lose weight. It induces weight loss, and by doing so, kind of vicariously, we get downregulation of free fatty acid flux to the liver, improvement in insulin sensitivity, less fatty liver, improved liver chemistry test, and ideally improvement on histopathology. So this is the phase 2B trial design. This paper was published in New England Journal in 2021. And you see there were 3 different doses of drug versus placebo, a very robust number of patients in each arm of 78 to 82. Patients were randomized here a bit differently. It was a 3 to 3 to 3 to 1 randomization schema, and treatment was a 1.5 years or 72 weeks. Again, had to be a biopsy-proven NASH. Here, F1s could be included as well as F2s and 3s, no cirrhotics. And what we see here are the published phase 2B clinical trial results on histopathology. This is looking on the left at NASH resolution, and you see the high dose group having a highly significant effect, 59% resolution of NASH compared to 17% for placebo. Also, relatively good responses for the lower doses, although not in a dose response manner. When we look at improvement of liver fibrosis with no worsening of NASH, while there was a treatment effect with the 3 different doses, it was not dose responsive and was not significant relative to the high placebo response rate of 33%. From a safety perspective, it was as you would expect with GLP-1 receptor agonist. There were more GI side effects relative to the dosing arms and placebo. The adverse events leading to premature discontinuation of treatment were generally low, mild to moderate, again, mainly GI related. When we look at the global perspective of semaglutide treatment, it is generally well tolerated. Again, the main take-home point is increased, although mild, incidence of GI tolerability. And I might parenthetically say that is applicable to every injectable in this field, whether it's an FGF21, an FGF19, a GLP-1, a combination GLP-1 GIP, or a GLP-1 glucagon agonist. Now let's turn to lanifibranor. This is a pan-PPAR agonist. PPARs are nuclear hormone receptors that have key regulatory functions in metabolism, inflammation, and fibrosis. You see here a cartoon illustrating the effects of PPAR alpha, PPAR gamma, and PPAR delta. And again, when we look at this particular compound, it works on all three of these. And ultimately, the goal would be to reduce in a pleiotropic manner steatosis, inflammation, NASH, and ultimately fibrosis. So I want to show you the results from the phase 2b study. This was recently published in New England Journal as well. This is a 24-week treatment study. So it's about 1/3 the duration of the semaglutide phase 2b trial. Patients were randomized in a 1-to-1-to-1 randomization scheme of low dose, high dose versus placebo. You had to have a biopsy to get in, a biopsy to get out. F4 disease was excluded, and these patients were stratified based on type 2 diabetes status. Very encouraging results from this publication in New England Journal. The primary endpoint and the secondary endpoints were met for reduction of at least 2 points on the SAF activity score and no worsening of fibrosis, a nice dose response relationship between placebo, low dose, and high dose. When we look at the key endpoint of key secondary endpoint of improvement of at least one stage of fibrosis with no worsening of NASH, 42% for high dose, 24% for placebo, highly significant, and the same for NASH resolution, 45 versus 19. So very encouraging news there. How about safety? Well, generally well tolerated and balanced across treatment groups relative to placebo, mainly mild to moderate in duration. There was some increase in weight with the high dose group, probably linked to the PPAR gamma activity of this particular drug. And while the peripheral edema was not dramatically impacted, again, it's a relatively short-term trial, and we just need to see in the phase 3, which is a much longer duration treatment trial, if there's a concern that rises with that, but hopefully not. And this is the phase 3 clinical trial design. It's 72 weeks. You see low dose, high dose versus placebo. We get to that surrogate endpoint after 72 weeks to do the liver biopsy. And then what we call the phase 4 or the extension period out to a long-term outcome benefit. So keep in mind here, the phase 2b trial was 24 weeks in duration. Phase 3 trial, 72 weeks in duration, same doses of drug versus placebo, stratification here on type 2 diabetes and fibrosis stage. And then finally, resmetirom. This is a thyroid hormone receptor beta agonist. It is very selective to the beta portion of the THR hormone, and it is liver specific. So there's does not appear to be binding outside of the liver, which is encouraging because the alpha component of THR has cardiac toxicity linked to it. So we don't see that in the phase 2b program, and heretofore from the phase 3 data presented, there has not been evidence of THR alpha activity. What does beta agonism do? It's important to reflect on fatty liver disease and understand that in the setting of non-alcoholic fatty liver, the liver is relatively hypothyroid. It cannot convert T4 to T3 effectively. You get a buildup of reverse T3. So when you give a drug like resmetirom or other THR beta agonist, the idea is that it resets the thyroid function in the liver by allowing conversion of T4 to T3. This occurs through several different processes. One of those is mitochondrial biogenesis. The impacts here are lowering liver fat, reducing lipotoxicity, impacts on lipoproteins, LDL cholesterol, triglycerides, and ultimately, hopefully, positive benefits on histopathology. I'm showing you now results from the phase 2b trial published in Lancet a couple years ago. The primary endpoint at 12 weeks was liver fat content reduction. On the left, you see bar graphs showing that relative to placebo in the blue bars, that the drug, it was effective. It did hit its primary endpoint. There was a dose-dependent 50% reduction of hepatic fat at the 80 milligram dose. It's also important to remember in this phase 2b trial, the majority of patients were dosed at 60 milligrams. Moving into phase 3, based on the data you see here, with effects of 50 to 64%, looking at 80 and 100 milligrams on liver fat content reduction, those were the two doses taken forward into phase 3. Now, there were key secondary endpoints looking at liver histology, particularly reduction in resolution of NASH and fibrosis, but also looking at liver chemistry test and lipoproteins. So looking at the phase 3, this is the design of the phase 3 trial. There actually are 3 phase 3 trials, technically 4 phase 3 trials with this particular compound. There is the Maestro-NAFLD-1 trial, which looked at non-invasive assessment for safety, tolerability, and also looking at the NITs that Dr. Afdhal talked about briefly. That was reported out at EASL this past summer, and it did show that it was safe and well tolerated, and several non-invasive tests moved in a very positive direction. The Maestro-NAFLD trial is the registrational trial. It is 2 doses of drug versus placebo. Treatment is for 52 weeks, a liver biopsy to get in, a liver biopsy to get out. The primary endpoint is a dual endpoint of either NASH resolution or fibrosis improvement of at least 1 stage without worsening of NASH. There is an extension trial looking at the Maestro-NAFLD-1 non-invasive data. Patients were continued on drug after the end of that trial. If they were on placebo, they were switched over to drug. And then there's a recent phase 3 trial in well-compensated cirrhotics called the Maestro Outcome trial that has recently been launched. When we look at the safety summary from the double-blind arms of the Maestro-NAFLD-1 trial, we see that it is generally very safe, balanced across all adverse events, are balanced across the treatment groups, again, mainly mild to moderate. When we look at the most frequent adverse events, they are also GI-related, diarrhea or loose stools and nausea. Consistent with the phase 2 data, there was a minimal reduction in prohormone-free T4. I get asked about that often. This is not impacting TSH. It's not impacting active free T3. When we look at some of these key secondary endpoints from the NAFLD-1 trial, we see reductions in LDL cholesterol, ApoB, as well as triglycerides if the baseline was set at higher than 150 milligrams per deciliter. And statistical significant reductions were seen for LDL cholesterol, ApoB, MRI proton density, fat fraction, the gold standard for fat quantification, and CAP, the controlled attenuation parameter from FibroScan. When we look at MR elastography and FibroScan, there are a couple caveats here I want to bring your attention to. We only looked at people on MRE who had a baseline liver stiffness measurement greater than or equal to 2.9 kPa, and for FibroScan, it had to be greater than or equal to 7.2 kPa. Next, we looked at what is the coefficient of variance of these scans. In other words, what is the range of that scan where there could be some, where we could feel confident about the reproducibility of the image. For MRE, the Kiva database has showed us that 19% is that number. So we set that as our threshold looking for improvement. For MRE, 24% of the double-blind and open-label 100 milligram dose had improvement of at least greater than 19%, and it was 22% for the 80 milligram dose, 11% for placebo. About half of those patients worsened that were on drug relative to placebo. You see that illustrated here as well. Shifting to FibroScan, a dose-response relationship again seen in those that improve their KPA by at least 2, or at least a 30% relative improvement. So you can look at it from an absolute change or relative change, again, a dose-response relationship there. So again, people ask all the time with resmetirom what to expect in case of positive top-line results. Again, I think we should still hear the top-line results from the Maestro NASH trial in Q4 of this year. If they're positive, I think there will be a regulatory file submission, and then we go through the regulatory and review and approval process. Then there's pricing reimbursement negotiations with the payer, and finally patient access. In general, for drugs that have fast track approval, and Madrigal has that for resmetirom, it's generally approximately 1 year from reporting out of the trial results until there is patient access, roughly 6 months to gather all the data and submit the new drug application, and then 6 months for the FDA to review. So where's my perspective on NASH cirrhotic potential for drugs? I list the 4 drugs here that are in phase 3, as well as 2 drugs that have completed phase 2 with liver biopsy results. And I see safety and tolerability probably being the safest and most tolerable for the oral resmetirom and for the oral Poxel 065. The others are generally safe and well tolerated also, although they get just a different color here because probably not quite as safe as the other 2 from a tolerability perspective either. Now, when we look at results, I clumped these into 2 endpoints for histology, fibrosis improvement, and NASH resolution, and then insulin sensitivity and lipid benefit. Resmetirom hitting from the phase 2 trial on lipids and NASH resolution, obeticholic acid, again, phase 2 and phase 3 results on fibrosis improvement. Lanifibranor phase 2b results showing impacts on all 4 of these parameters. Semaglutide impacts from an injectable semaglutide on insulin sensitivity and NASH resolution. The PXL 065 drug on insulin sensitivity and fibrosis improvement, and efruxifermin, another injectable FGF21 on all of these parameters. So very, very encouraging. What about cirrhotics? When we look at extrahepatic benefit on the vertical axis and histopathologic benefit on the horizontal axis, obeticholic acid not having impacts based on the reverse trial on histology or extrahepatic benefits. Semaglutide having good effects on extrahepatic impacts with glycemic control and lipids, but not a dramatic, necessarily a dramatic improvement on histology. When we look at efruxifermin, we see impacts on extrahepatic benefits, as well as, this is a small study of less than 20 patients having biopsy in the cirrhotic arm, but a third of them actually had regression of fibrosis from F4 to F3. So encouraging results there. We need to see more data. And then finally, belapectin. This is an interesting drug. It's a galectin-3 inhibitor. It's an infusion given every 2 weeks, and it is the only drug in development that is looking at prevention of progression of disease. And it is also the only drug that has an adaptive phase 2b/3 clinical trial design. And here you're looking at prevention of progression to varices. And in their phase 2b trial or phase 2 trial that led to a repeat phase 2, phase 3 study, there was prevention in a small subset of patients, prevention of progression to varices. Has no benefit on extrahepatic, no extrahepatic benefits. And then finally, on combination treatment, the ideal drug, I think it hits all of these parameters I see listed here. And I don't think that a single therapy is going to be enough to do all of this, which gets us to drug development. And I think the future of drug development is combination therapy. So again, we want the ideal combo to be oral for long-term. If it's injections, maybe that's induction or intermittent use. We want it to be well tolerated, safe, synergistically improves histology and extrahepatic metabolic profiles with enhancement of long-term outcomes. To me, this is from Mike Charlton. This is what we're looking for. The Jamaican 4x100 meter relay record. All of these sprinters were world-class in their own right. They got along well with each other. They had complementary strengths, similar endurance, and came from the same general location. Some early trial here looking at a GLP-1, an acetyl-CoA carboxylase inhibitor, and an FXR agonist. And what did that show? It actually showed benefits on liver fat content reduction. You see illustrated here, as well as body weight. And I showed body weight here, I'm sorry, and then liver fat content reduction here. So where are we headed in the future? I think to get to precision medicine, we need to attack fibrosis. We can do that actually very provocatively, some animal data with CAR T therapy. We can work on the gut microbiome. We can target genetic polymorphisms, and several drugs are doing that now. And then therapeutic oligonucleotide data, and several studies doing that. So with that, that's the whirlwind drive through drug development. And let me turn it back over to our moderator. Thank you.
Thank you both, Stephen. That was incredible. Dr. Afdhal, Dr. Harrison, as always, fabulous presentations. And you're right, there's so much information in such a little bit of time. We have about 5 minutes for questions. I do have one very specific question from Dr. Addy, who's been waiting very patiently since Dr. Afdhal's talk. Given that renal function determined by serum creatinine might be affected by musculature, could checking the liver molecule cysteine C be more reliable as a marker for kidney function, even if NAFLD exists? Anybody?
Sorry, I needed to unmute. There was actually a lot of data looking at that in the past in different liver diseases, not so much in NAFLD. But the answer is that yes, you can look at renal cystatins to look at function in terms of renal function. But you know, overall, in the NASH population, until you get to cirrhosis, I think creatinine is fine.
Ned, what do you think? What do you think about the urine albumin creatinine ratio? That's another one that may be that I've heard a bit.
Yeah, you know, again, I have seen people looking at that. One of the problems that I think that we have with all of these analyses is that they're done in highly specialized populations, and the reality is that if we get a therapeutic, and I think back to the Hep C days, you know, what did we used to do in Hep C when we used interferon? We used to use liver biopsy as an excuse not to treat people. Then we went to DAAs and we wanted to treat everybody. So we didn't want liver biopsy. In fact, we didn't want to do anything except diagnose cirrhosis and treat everyone. My feeling is that if you're right, and some of these relatively benign drugs with good metabolic profiles that help both cardiovascular and metabolic profile, like maybe resmetirom, they will have a huge impact in the area of all of these patients that are in primary care with NASH. And I think that if we're going to use a biomarker, simplification is the key. And when you link biomarkers to therapeutics, what you really want to do, making the assumption that therapeutics are expensive, is you want biomarkers that will convince payers that you're getting the effect that you want to see. So, you know, we need something incredibly simple that does that, that is
Right.
cost effective to be able to generate true meaningful change in what we do. So I have to say that I love all the research that's taking place in metabolomics, in glycomics, in using things like SomaScan. But at the end of the day, their role in clinical practice and clinical development is going to be very limited. Their role in clinical research is superb. It's really interesting, you know.
We have just 2 minutes left and a lot of questions. We're not going to make it, so we're going to have to do this again in the new year. But so maybe you guys can combine this into one. I'm going to put the two questions together in one answer. Maybe when you're looking at exercise and you're looking at diet and medication, the first question is how important is exercise specifically versus the medication and diet side? And there's another question about probiotics. So maybe you can combine those together.
Let me just take a quick stab at this, and I'll let Dr. Afdhal have the final say, since he's the senior to me, and just an icon in the field. It's just been terrific to work with him on this project, as well as you, Michael. So there's a recent publication in Nature Medicine actually looking at Fitbit and steps. And it was very, you should read it. It's Brittain, Brittain is the senior author. Fascinating work showing that large numbers of patients, so over 6,000 or so, followed for a long period of time. 8,000 steps, greater than 8,000 steps a day, had a dramatic impact on obesity diabetes and outcomes. And that there was a commentary there as well that looked at data from the NHANES database showing when you compare people who walk 4,000 steps a day to 8,000, there's a 51% overall mortality rate decrease. I think it's clear that exercise is going to help patients with this disease. Will it help their liver disease? There's no data that walking 10,000 steps a day is going to reduce liver fat or impact steatohepatitis or fibrosis. However, again, we don't want to be so myopic that we just focus on the liver. We want to treat the patient. And so ultimately, there is good data that exercise is incredibly important. Diet is as well. We never want to treat a patient with a drug and forget foundationally lifestyle modification. That remains the foundational principle to treat these patients. So let me stop there.
Totally agree with you, Steve. Lifestyle modification is the #1 thing. And that's what we need to promote to all of those people who, when we evaluate them, don't have at-risk NASH and we leave them in the primary care. That's where the exercise and diet comes in. There's one study from Dublin where they took 20 patients with fibrosis and put them on an intensive exercise regime. And irrespective of weight loss, they actually biopsied these patients at 2 time points. And I think the duration was very short, was about 3 months, but they showed a significant improvement in NASH and also in some patients an improvement in fibrosis. So, exercise is one of the best treatments for metabolic syndrome and insulin resistance. So let's all exercise more. I have a Fitbit. Actually, I have an Apple Watch.
Me too.
Yeah.
Okay, well, we're out of time and we have more questions than we have time. So I want to thank both Dr. Afdhal and Dr. Harrison for outstanding presentations today. And of course, Sonic Insights for sponsoring. Please take a moment to complete the post-webinar surveys that will be sent to you shortly. Thank you all so much for attending today and wishing you all happy holidays and a healthy and safe new year.